Good morning. I'm going to go ahead and get us started. Good morning and welcome to Rewiring Your Agency for the Value Era, presented jointly by the Alliance for Home Health Care Quality and Innovation and the Visiting Nurse Associations of America. This session is being recorded. The continuing nursing education activity has been approved for one contact hour by the Maryland Nurses Association and accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. In order to receive your certificate of completion, you will need to attend this program in its entirety, complete the evaluation, which is available on your conference app. Certificates of completion are available at the registration desk. Our faculty has disclosed no financial conflict of interest. A copy of the full disclosure sheet is available on the table outside the room, and I am going to pass around the sign-in sheet for all the nurses who need to get your CEUs. And with that, I'm going to introduce today's presenters. Arnie Cisneros is the president of Home Health Strategic Management. He has 30-plus years of experience as a physical therapist across the care continuum, and he serves as a post-acute consultant for multiple Pioneer ACO systems. In 2012, he was awarded a bundle payment for care improvement pilot program in conjunction with the Detroit Medical Center to address episodic bundling for lower extremity joint replacements. The 2016 CCJR initiative is based on Model 2 bundling pilot programs for total joint replacements, which Arnie has managed since 2014 for the DMC. Kimberly McCormick is a highly accomplished nurse consultant in the home health industry, is Executive Nursing Director for Home Health Strategic Management. Her 20 years experience in home health, 8 spent as administrator of a home health agency, has given her the experience and knowledge to provide unrivaled insight into the home care arena. Kimberly served as an associate consultant with the Home Health Strategic Management for 2 years, during which she established herself as an expert in the area of utilization management of home health services. During her time as an administrator, she achieved deficiency-free surveys by the Joint Commission, deficiency-free Department of Health and CMS surveys, and a 0.42% error rate on an ADR audit. Kimberly authors the HHSM nursing newsletter and is presenting nationally on home care topics and care models proposed by CMS and MedPAC for the future of home health industry. Kevin Smith is the controller of Spectrum Health Continuing Care, has 30 years of healthcare finance and operational management experience. He is the financial lead for all of Spectrum Health's post-acute services, including home health, hospice, private duty nursing, inpatient and outpatient rehabilitation, long-term care, long-term acute care, and adult foster care. Prior to joining Spectrum Health, he spent 21 years at the Detroit Medical Center as the CFO role for both post-acute and acute facilities. So with that, I'm going to turn it over to the presenters. Thank you so much.
Good morning and hello, everybody. Thanks for attending. I'm Arnie Cisneros. I'm president of HHSM. We're going to talk today about how we worked with Spectrum VNA in Grand Rapids, Michigan to help them identify a value process and rewire their care. So as Joy had mentioned, we have no disclosure statement items to review, and under learning objectives, we want to identify the demands of the home health value reforms and areas of the home health model that relate to these value demands. Outline strategies HHSM has employed to achieve value-based improvements for home health providers utilizing CMS Home Health Chapter 7 regulations. And then last, present case study testimony from VNA home health providers regarding value improvements. So just generally, what we want to talk about is how we view the delivery process, and our model is based on the belief system that we have the acute care patients of the past, since the people we're treating in post-acute scenarios used to be in acute care beds much longer. So the acuity of our patient population is increasing, the reimbursement is decreasing, the regulations are increasing, and how you need to package programs for the future is very important for our clinical approach. And our MO is to treat these patients the way that the continuum treats patients, which is timeliness, acuity focus, changing care targets, and efficient, compliant programming is basically the backbone of the CMS home health model. And that's where we focus. So when we're trying to rewire for value outcomes, we try to follow a couple belief systems that we have, which is the demands of the industry have moved past the ability of the frontline clinical staff to manage independently. We need to help them through these care models. They're not as obvious as the previous ones were. And not only do we need to be in the home consistently, but now we need to make things happen if we want to have a successful program. And as pre-claim review dances around our landscape and value-based purchasing continues to come forward to us, and ACOs and managed care providers assess us in terms of publicly traded data, very specifically star ratings. And we all heard Eric Wexler and Mark Biotta make comments about this, and I really thought those were some very good and focused ideas for the future. And I thought Mark Biotta made a really good comment when he was wondering about, during his career, whether home health was selling the patient short. And he wanted to make sure that wasn't happening, so he started to be involved on a professional and regulatory level to see how to make the program better for our patients. And I would propose that's something we need to ask ourselves about our clinical programs. Are we selling our patients short? Are we really doing what we need to do for our patient? Are we really not providing unsafe care when it takes us 5 days to get a nurse out or a week to get a therapist out? Because why would we think that that doesn't provide unsafe care? People fall during those times. People have med errors during those times. They go back to the hospital. And we decided it's not unsafe care because we decided. So I think we have to take our broadband view outside of our personal industry and look at it from the outside and say, how do we improve our patient delivery? The patient that we're seeing is someone's aunt. Do you want your aunt waiting around 7 days for a therapist to get to her home after a hospital admission that started with a fall? So those are things we have to be open to discuss as we're moving forward. So continuing with how Spectrum VNA reinvented care to achieve success in value terms, Spectrum VNA, a division of Spectra Health, addressed volume-to-value reforms by seeking patient-centered processes that they rewired in terms of care development, delivery, and management protocols for improved outcomes. By reinterpreting the Medicare Benefit Policy Manual, Chapter 7, in terms of value, Spectrum VNA addressed multiple elements of the home health model that related to desired outcomes. Home health management processes rewired for value outcomes are addressed chronologically in this presentation. So what are the things we're looking for? Well, we've been establishing and installing utilization review programs for about 15 years now to providers across the country. And sometimes we'll see our program take on real great clinical improvements for the agency, but those may be in fact short-lived if they're then undercut by inefficiencies in the intake department, the scheduling department, and the productivity integrity of the agency. If we can't expect a certain amount of care delivery out of a staff, or we can expect it and we don't get it, the model starts to soften. If we can't make sure that we're intaking so that we get all the information so we can get out the next day, the model starts to soften. And I think those are important areas that we now pay attention to in every opportunity that we work with agencies, because we want this model to last after we leave. Start of care Oasis accuracy, specifically in the case mix questions. So I want to make sure we understand the difference between regular Oasis education and our Oasis focus. Regular Oasis education, which is certainly needed and very professional and essential for our industry, starts with question 1 and ends with the last question of the Oasis. And it's very hard for the individual clinician to pick out the case mix questions, which are really the extra credit questions of the Oasis. So our Oasis accuracy focuses on 25, actually now 27 case mix questions with the new Oasis. Very specific. You might notice when we go through some of these questions, they are the questions that relate to the old OBQI scale that we used to have. These are the topics that people fail or succeed in home care with. And these are the items that send people back to the hospital. So how do we focus on those sort of elements of moving people from not being back into the hospital? I have managed a bundle for a Pioneer ACO for a number of years, so I'm very conscientious of the readmission issue from the hospital side or the ACO side. And I think that's something that we need to be open with regards to what sends people back to the hospital. And the case mix question focus really helps create an individualized patient care plan for the specific patient we're seeing, not for a group of patients in which the specific patient we're seeing is included. So we don't want to treat a patient the way we would treat 1,000 COPD patients. We want to treat the patient the way we should treat this COPD patient. What are their dynamics? What happens with the response to their treatment, and how do we modify care delivery to fit that? HERG optimization matches our case mix changes. Case mix tends to go up 10 to 20% at a minimum if we're focusing on accurate questions and answers. And HERG optimization accompanies that. But in no way is our model derived to create increased case mix or HERGs. That's how the PPS model works. When you do a better and more efficient clinical program, these are the results. So when we reference Chapter 7, which is the Medicare chapter of the CMS beneficiary regulations, we're just following the program from PPS and trying to perform it as efficiently as possible with a patient focus rather than transition the less patient-focused home health model that we've had traditionally and trying to work it into the new model. We really have to break the glass on some of these items and reinvent them from the ground up in order to get the value outcomes that we have. Home health care plans in value terms. So let's focus on the first 30 days. We haven't written a greater than 30-day care plan order in 10 years. We have no belief system that our frontline clinician can predict in the first hour and a half to 2 hour visit with the patient what the patient's going to look like on day 31. I have no belief system about that. I think if we really talked about it, we'd all agree with that. So why would we make a plan and commit resources, staffing, and utilization for 60 days in the first hour and a half to 2 hours? So let's focus on 30 days. Our approach is, who do you think nurses send back more in the first 30 days to the hospital? Patients with a 30-day order or patients with a 60-day order? It's the patients with a 60-day order because the nurse thinks I've got 2 months to solve this subconsciously. The 30-day order, they focus on that. And that's a traditional healthcare programming utilization model. When Medicare created DRGs, the less the hospital had the patient, the more they had to focus on getting them better and achieving the clinical outcomes. And that works at every level. Same thing with SNF outcomes, inpatient rehab. So that's something we need to know about care delivery. Staffing, develop value-based frequency and duration orders. So we're really labile to the fact, since we work across the care continuum, that none of our nurses and therapists write their own frequency and duration orders for any other Medicare patient outside of home care. And that connects us to the inefficiency and the volatility and the variability of each one of those happening. So when you think about it, you have about 45 people determining your utilization on an individual patient basis between nurses and therapists. How can you make sure that that's standardizing the outcomes that you want? And this is how we look at that model so that we can reinvent it to create the outcomes. In episode management, we want to drive patient care plans to discharge outcomes because we need to remain focused on the discharge outcome as the patient changes from the treatment we've given them to date. So 7 days later, your patients are different than they are on day one. How are we readjusting and refitting the care plan to that new patient? So I think those are really elements that create value programs because you could be spending another week addressing an item that a clinician hasn't internalized, he's already resolved, and moving on to the next level of care delivery. Clinical content, assuring skill and value-driven programs. So how do we make sure that we have the required documentation elements on both nursing and therapy level so that Medicare recognizes the value pathway that we've got our clinicians on? Next, scripting for value outcomes. It matters what we say. Most people in our industry understand that many of our clients don't understand the benefit. And I think that's a crucial element. This is how your benefit works. Let's make sure that we get what you need out of your benefit. It doesn't give you home health aides for 3 cert periods like it used to. Now it does different things. So I think that's really important for us to make sure that all our clinical staff is on the right page with that. Addressing star ratings. So engineering desired results. We kind of approach it from a different model than I think your average provider approaches it. We think care delivery equals clinical outcomes. And most people approach it from the, let's focus on the care delivery side and hope that we get the outcome. And we reverse re-engineer it from that. Here's the outcome. What do we have to do over here to get that? And let's remain focused on that because it's all about the outcome. And when we focus on the outcome, the focus becomes patient-centered. When we focus on the protocol and the process, it becomes clinician and provider-centered. And that's really an important element to understand, to look back down the care continuum to see how we can create these results. Assuring patient satisfaction and outcomes is related to both of those elements. If the patient thinks the benefit provides something else, and you let them think that throughout the episode, guess what happens with your satisfaction rating when you don't deliver that? So it's really important to be conversant about that and to make sure that your clinical staff is conversant about that. So that's our approach, and we'll talk specifically about that. Decrease staffing volumes and costs. We tend to decrease nursing visit volumes because we approach it with this could possibly be done this quickly, rather than it might take us this long to approach to clinical utilization. We want to make sure we manage that from in the provider's office. Significant decrease in potentially avoidable events. I think we're going to talk about Spectrum's 57 decrease in potentially avoidable events. Assures care plan development for pre-claim review approval, and establishes permanent audit-proof home health programming. So what Medicare is looking for today is skill and value that are based on required documentations for both nursing and therapy elements. So when we assure that those 5 elements are in care programming, then audits the denials aren't coming from the audits, because again, we're just following the CMS care model. So this is really continuation of utilization review in home health, which is the development and delivery of home health services created from a utilization review PPS compliant perspective. Patient-centered, case-managed care modified in an ongoing manner for patient response to treatment. UR managed home health produces level of clinicals and fiscal outcomes not regularly seen in home health, as it creates the value-based episodic programs of the future. Specific targeting of best practice care, efficient delivery, and desired patient satisfaction outcomes in CMS terms. And regarding CMS terms, that relates to the Medicare Benefit Policy Manual, Chapter 7. The Medicare Benefit Policy Manual, Chapter 7, details the specifics of efficient care in accordance with value reforms, and yet it remains the least used reference in the home health industry. Chapter 7 addresses home health regulations, coverage of reasonable and necessary services, use of caregiver, general home health principles, use of rehab to include PTOT and speech, required documentation elements, etc. Chapter 7 reinterpretation is an essential component for transitioning programming and documentation trends. So I think many times when I present this is what I hear back. What's Chapter 7? So if we often don't know what Chapter 7 is, you clearly are not having a clinical staff guided by those regulations. And I think that's really an important cornerstone for us to start. So now I'm going to turn it over to Kevin Smith, the controller from Spectrum Health, and he's going to talk about it from a CFO perspective, and then we'll give it to Kim McCormick, our clinical executive, and let her talk chronologically about how this was achieved.
Okay. Thanks, Arnie. Good morning, everybody. It's a pleasure to be here. I have had the distinct privilege to be with Spectrum Health for 2.5 years now. Let me give you a little background on Spectrum Health, who we are and where we are. So Spectrum Health is a large regional medical center, a health system, with a large medical center in Grand Rapids, downtown Grand Rapids, with a tertiary care hospital, level 1 trauma, a children's hospital, cancer, and a heart facilities that are separate yet attached in this large medical complex. One additional hospital right outside of Grand Rapids, which is a community-based hospital, and then 8 regional hospitals throughout West Michigan, primarily north of Grand Rapids, but some of them, a couple of them down south of Grand Rapids. It also has a fairly large and growing employed physician practice, a medical group. It has Priority Health, which is the second largest commercial insurance program in the state of Michigan. And then it has continuing care, and that's where I work, and a couple of my colleagues here work at continuing care at Spectrum Health. And then within the continuing care group, we have a significant complement of the post-acute services that you would expect. Home health is our VNAs. We have hospice. We have private duty nursing. Those are wrapped together as our Spectrum at Home services. We then have long-term skilled nursing facilities, long-term care facilities. We have adult foster care programs. These are houses that are primarily we use for neuro patients with, brain injury and those type of significant long-term needs. We also have a long-term acute care hospital. We have within our management responsibilities an inpatient rehab center or unit that's inside our Blodgett Hospital, which is near Grand Rapids, and we have multiple outpatient rehab locations. So quite a full spectrum, as we like to say, of services in post-acute. So within the home health area, we have 2 agencies, 2 VNA agencies. One that is based in Grand Rapids, which we call VNA South, a very clever name, I know. And it is the largest of the two. It's about 1,500 census daily. And then we have one that is in the North, VNA North, as we call it internally. These are our internal names. Outside is really VNA as known by the public. And that's in Fremont, Michigan, the home of Gerber baby food, by the way. And that's about ADC, about 500 on a regular daily basis. So as we looked at our operations, we've done a lot of work in integration, and we looked at our results both operationally, clinically, and financially, and realized that we had inconsistencies. We had opportunity for improvement. And we looked at that, and we thought, we started having our conversation with Arnie and team and said, what's the opportunity here? Should we move forward? What's the viability of putting this significant change in how we would provide services and manage services forward? And lots of conversation about that. We did sign a contract and start this program in February of 2016, so about 14 months ago. Again, this team, my colleagues here, we were involved very much before that, and really lots of cost-benefit analysis, looked at current cases. What do we think? How could we make improvement? Would this UR program work here? So we did a lot of that. We had a lot of initial conversations once we signed the deal. Then it was really kind of going to the line staff, line management at VNA, and really finding out, having conversations with them, putting the groundwork down, understanding this was going to be a significant change in how we provided care, how we provided services, and how we did utilization management. We did level setting with the staff then. We had education. We had the Oasis training that we did with the staff to make sure that everybody was on the same page, looking at things the same way. So that was about 4 or 5 hours of training with each individual staff member, and we did that. Talked to them about the importance and the benefit of this standardization of protocol, the removal of variation, that really, if you remove the variation in the process, then you can focus on the individual attention for each patient as needed. So you have change in what each individual patient needs, but you have a process that's the same. Talked about having those start of care calls, having a clinical line, having the staff out in the field communicating with the staff in the office, the utilization management staff in the office on an ongoing basis. And then we went live in April of 16, so just about a year ago. We said we do this for all our Medicare cases. So it's really our episodic payers, our Medicare, Medicare Advantage. Excuse me. But really when you do something like this, it impacts every patient. It impacts how you do business. So we're about 50% episodic payment, and between Medicare, Medicare Advantage, and then the rest of the business is a per visit payment. But we saw changes in all of our business. Obviously, we had lots of goals, as you would expect, right? We not only had my goals, which were the financial ones, not that they weren't important to you guys too, but we also had quality and performance goals and clinical goals. We really wanted to see improvement in our quality scores. We wanted to see those star ratings go up. I think we're started at 3.5 today. We want to make sure we see that continue to improve. Very important to us, as well as the health system. We wanted to see a reduction in our readmission rates. We wanted to see a reduction in our ER visits. We did want to see an increase in our case mix. So, as I said, we're part of this medical center system. We get about 60% of our business for the home health from post-acute, from discharges from the hospital, over 60%. When we looked at our case mix compared to the state averages, we were below that. We felt that we shouldn't be below that there was opportunity, and we really should be above that. And then there was an issue and a potential opportunity there from a case mix standpoint. So we were expecting to see that. And certainly, we wanted to see improvement in productivity from the staff. So we thought that we could increase our RVUs per day, per workday. We thought we could increase our visits per workday. So, did I just talk about that one, guys? Okay, thanks. So what happened? So we've been doing this for a year. So what are the results? And frankly, we've been very encouraged and pleased with the results we've seen so far in this last year. We have seen improvement in our quality scores in quite a few, and Kim's going to go into the details about those, and so I'll let her do that. But we've seen those scores go up, and that's been good. The quality's been strong. We have seen a lower number of readmissions, so our readmission rate's better. Our ER visit rate is significantly better. That's very encouraging and good news. We've seen, as Arnie mentioned, the reduction in falls and avoidable events. We've seen an improved case mix. We've seen an improved case mix in the HERG levels. We're still seeing a change. We see a better rate at the RAP, at the initial bill, than the final bill. We're trying to close that gap too, but certainly overall an improvement in the case mix. We've seen an improvement in our staff productivity. This took a little longer than we expected at first, or it took a while, but we have seen that improvement. It's coming, and we've also seen a reduction in our visits per episode. We've seen a reduction overall, and that's really come from the nursing visits, skilled nursing visits per episode. So what have we learned? How was this? And as you guys can imagine, it won't be a surprise to anybody in this room if you're managing an agency that change is hard, and you have cultures, and when you change fundamentally how somebody does their job on a daily basis, you're going to get some pushback, and we did, and we had, and it's culture, and it's been providing, the Spectrum VNA has been providing service in the community for years, and much of that's great, and they're doing a great job, but that would be like telling me I can't have my cup of coffee first thing in the morning. That would be difficult. So change is hard. We dealt with that change. The team did a good job working with that. And how did we do that? It really required ongoing commitment to that change, making sure we integrated that change and we got that change to stick. We'd have weekly meetings. We still do, and we will continue to do weekly meetings. We use real data. We update that data on a weekly basis. We use our SHP system to grab that information. We tackle issues as they arise. The team internally talks about them. We talk to the HHSM team about them. We make those changes. Internally, we've got to make sure that what we do is right for the system. Sometimes HHSM would say, rip that Band-Aid off, and we'd say, no, we're not going to rip that Band-Aid off. We're going to figure this out so that we do things well, and the staff stays on board with us. So, but I would say the use of doing that and the use of real data was great. So it was very helpful, and it's extremely important that you're using really hard data to do this. So overall, we're very pleased. In fact, so pleased that we're going to continue this. VNA North now we just implemented at VNA North, so we're expecting same results there, and so far so good. And with that, I'll give it to Kim for additional comment.
Can everyone hear me? Good afternoon, or good morning, actually, right? All right, thank you so much, Kevin. So I'm going to take you through the chronology of what we did with Spectrum, and I think it's really important to understand what that process is, how Spectrum started to really recognize the changes that they sought for their agency. So through the Search UR process, one of the first things we start out with is the introductory orientation for all staff. This includes billers, people in the office, getting everybody on board with what that change is going to be. So kind of decreasing those silos amongst even inter-office staff, bringing clinicians on board, management on board, and helping everybody recognize what that vision of change is going to be. As Kevin had referenced, change is never easy. So how do we get to that? Talking to administration, management, supervisory, clinical, taking a look at the history of home health. How do we get to where we're at? And for those of you who have ever heard me speak, I like to always talk about the history, which I won't go into greatly now, but understanding the legacy of home health. I've been in home health for over 20 years. I understand exactly what it used to look like before Oasis. Anyone else in the room remember those? I like to refer to them as the good old days. BID heparins, TID wet to dries, where we came from, and understanding that legacy of the history to where we are now, and how we pull that control back out of the cars and inside the agencies or systems to gain that control in a very patient-centered model. So instead of talking about things like scheduling or how we got here or what's going to work for me or how many cats are in the house, really looking at each patient as though it was our favorite aunt and how would we want that to play out, and therefore moving it into a very patient-centered model. We addressed things when we started with Spectrum, the intent of the Medicare Home Health Benefit Manual. PBS has been around since 99, 2000, right? So when we made that change into Oasis and what that model really meant and why we have to get that accuracy at the time of Oasis and start of care, breaking those silos. And I'll address that a little bit more. Again, just talking about the history of the clinical staff, the home health model, what things need to change. Beginning communication and data tracking. So, oftentimes in home health, we'll say, well, we don't really have a problem with that. That's not really our issue. I've been involved in that many times and said to somebody recently, missed visits, is that an issue? Because we all agree there's no such thing as missed visits anymore. So, do you have an issue with that? No, absolutely not. Let's pull the report and take a look. Pull the actual data from it to find out it's 13 pages long from the past month. So we use real life data, real-time tracking, that's what we implied with Spectrum, to really start to recognize the facts of where are we at today, and this is what we use as the platform to move forward. Clinical orientation, big piece. With Spectrum, a large clinical orientation that also encompassed Oasis training, like Kevin had referenced, really focused on the case mix questions. How many people in here have sat through Oasis training? Painfully. We focus on those case mix questions, which in the PPS model, the accuracy of those is everything, not only for financial stability, but how we determine the accurate deficits of that patient profile through Oasis, and therefore creating a plan of care that's drived toward those deficits. And that's the beginning phases of how we achieve outcomes. So there's been a lot of great conversations and a lot of great classes over the last couple of days about ACOs, bundles, where we're heading to. These are the beginning stages for how you start to become a partner in that, which is what Spectrum exactly did. We take a look at the required documentation. So in our search process, what we implied with Spectrum was the Medicare 5 required elements of documentation for both nursing and therapy. And so taking a look at that in real time based on those 5 elements of what's required for how we create defendable, audit-proof, justified visits. So no longer are we looking for volume, but rather value, which is what Medicare has always been looking at, and where we see those audits really starting to pick up speed again now. But creating that profile and teaching the clinicians of no longer can we just go in and say X, Y, and Z. We have to create that platform for these defendable items that create that for the agency and protect the patient. And when we really start to do that, it gives clinicians a whole different outlook of, all right, now I understand why I'm in here. Not that they didn't before, but it brings it home to the value model of efficiency of every visit, defendable documentation, and how we move a patient through the in-episode to achieve the goals of care. So really focused on plan of care creation and achieving that, and that's, again, how we start to increase the outcomes in a very accurate and meaningful way for the clinical staff as well as the management staff. From that component, we really talk about what we put in the process and what we implied in Spectrum was in-episode management. Oftentimes in my history, when we looked at everything retrospectively, right? We waited till we had a problem. We did chart audits after the patient was done. I remember being responsible to do quarterly audits, so many every single quarter, and I'd sit in a room and do audits and turn them in. And one day I thought to myself, where did these things go? And they said, well, into the book for the wounds, and then this way when we want to reference it, we could take a look and see what happened. I thought, shouldn't we do that in real time? So the in-episode management process that Spectrum is now using requires clinicians to meet with their supervisor every week to go through their caseload. Length of stays are going down. Like Arnie had referenced, we look at a 30-day and how that reduces rehospitalization and ED use. It's my favorite aunt. It's your favorite aunt. Don't we want somebody to be doing a case conference every single week on the progress to goals? So very much think about it like the continuums, all the other healthcare continuums. In a hospital, we give report and we get report every single shift, right? Home health, no different. How do we start to collaborate that in a meaningful way to achieve outcomes, decrease rehospitalizations, ED use, turn it from a retroactive to a very proactive approach in protecting patient care and delivery of services? So like we had referenced before, we do the Oasis education, which is great. Clinicians usually come in, and at Spectrum was no different. What we see all over the country, everybody kind of comes in, they're kind of hunkered down, arms crossed, another Oasis training, right? And by the end, it's very interactive. We found that to be the same with Spectrum. Great interaction, open conversations. Actually using the Oasis guidance manual, it's amazing. No matter what part of the country we're in, when I train on that, I say to clinicians, now how do you do the Oasis? Where's your guidance manual? And they say, what? We just read the questions and answers. And anyone who's ever viewed an Oasis guidance manual knows if you're just looking at the questions and the answers, you're going to be wrong more than 80% of the time, because that's not what they're asking us. So how do we imply the intent, the specific responses? And that's where we start to gain the accuracy in the patient profile. So in a very patient-centered model, which Spectrum has put into place, even at a higher level than they were focused on before, you start to then create that profile for the patient very accurately, and with that comes the appropriate payment. Medicare set up the PPS model not to put us out of business and for us to lose, but to create that accurate profile, to be paid accordingly to the services the patient needs in order to return back to their prior level of function, and that's where we get it. So clinicians are required to use their manual. They call in for a live start of care call. So every Medicare admission or episodic admission is called in to a QA team where we're actually giving report live. We're talking about Mrs. Smith. You'll call in, I'm talking to you, you'll tell me an Oasis answer, I've got the manual, you've got the manual. We're gonna dive in and look at that response and assure that that patient has the accurate profile for the agency to get the payment, for us to create an accurate plan of care with short and long-term goals, and how we derive that through in-episode management weekly to achieve the outcomes of the patient-centered model. Staff at the end, the arms come down. I know there's people in here who have experienced the Oasis training. They love it. They come up afterwards and say, this is great. It makes complete sense. And how that really starts to invigorate and change that culture to create more accuracy and autonomy at the clinician level, to use the guidance manual to improve those levels of care. Chapter 7, big one. Like Arnie had referenced earlier, no matter where we're at, clinicians will say, what is Chapter 7? I know that when I ran an orientation program, the first thing clinicians had to do before anything else was read the COPs in Chapter 7. In order to do what you need to do, in order to understand that, it's important to understand the rules. And we really utilize Chapter 7 as a guidance as CMS had put forth, not only for the 5 elements of documentation, but for the guidance of what's considered skilled, justifiable, medically necessary, and really utilize that to invigorate the staff to challenge and think about and start to move those pieces forward in their documentation. We're looking at creating, as we call it, a form-fitting plan of care for each patient, like Arnie had referenced earlier. Why in the world would we treat every single CHF patient exactly the same? Are they all the same? They're not the same. What if one patient needs 4 visits and one needs 9 and one needs 3? Why do we put them through these pathways that treat them all the same? And so the process that's at Spectrum through our search process is a form-fitting plan of care. Let's find out exactly what's wrong with the patient. Let's apply the utilization of visits and the services needed to improve those deficits and not blanket it into something different. So in the step-by-step guide for the redesign, first piece starts, and for those of you who've heard me speak before, I often refer to it as a relay race. Oftentimes, I remember early in my career, I'd get a name and an address, and I'd go to the home. Anyone else ever have that experience? So taking a look at intake, it starts at intake. From the minute the phone rings or the fax machine or we get an email, whatever it is, that's somebody's aunt, loved one, could be one of ours. But we look at that handoff and how important intake is to collect accurate data on that patient, to have medication profiles, correct diagnosis, understanding orders available to put services out there timely. Patients, shouldn't be waiting long times for physicians to call us back to give us PT orders. Let's assure that up front so that patient can move through the system very timely and accurately. Timely scheduling of start of care, getting out there, 24 hours, best practice. Rules are 48, but how do we start to look at that differently from a patient-centered approach instead of a scheduling approach of, well, we don't have the staff today, and maybe we'll get it done in the next 5 days, thinking about, again, a patient-centered model. And those are the things that Spectrum worked with us on to really move forward in monitoring scheduling and staffing and productivity and how that relates to timely initiation of care for patient-centeredness, but also outcomes. So our team with an Oasis Start of Care protocol. Again, we want to use the Oasis guidance manual. We talk to the clinicians on the phone at Start of Care to say, did we get the patient up? Oasis has never been an interview. We have to get that patient up and we have to do a functional walk, and therefore that's how we collect the correct data. So really having a great ability at the Spectrum level to talk to the clinician in the home with the patient. Oftentimes we hear, you want me to call in and talk about the patient in front of the patient? Yes. Why wouldn't we? Patients lay in hospital beds and SNFs. People are talking about them and their care all day long. We want the patient involved. And these start of care calls not only give accuracy, but give the clinicians a collaboration to not only gain accuracy in the profile, but to deal with any issues in real time. Things of non-compliance, the patient didn't want it. Those are all things of the past that really have to change in the industry as well. And those are the things that Spectrum really move forward on. Non-compliant patients are patients that don't understand what the beneficiary is, what the program relates to, how they can get their services. So how do we have a clinician out there individually making all these decisions on their own? Let's have them call in. Let's do a start of care call in front of the patient. That's how we start to gain accuracy, compliance, and really move the model in a patient-centered approach. Global programming is employed, looking at safety-based frequencies for services, applying utilization models of nursing, therapy, OT based on actual deficits, not just because, and documentation that then supports it. Safety-based plan of cares, based on those things that we find accurately in Oasis, and patient participation in the plan of care, like I referenced earlier, as Medicare has always required us to do, is huge. So think about the world where we actually have a patient involved at start of care and we can start to then make changes, answer questions, and gain compliance at that time. So we move those pieces forward with Spectrum as well. Obviously, the Oasis admission documentation for all disciplines, very identical to the MDS role in the subacute. Let's get that correct. Let's have somebody review it in real time and report, not 7 days later if we're behind on QA, right? So that's often a legacy of home health, and these are the things that Spectrum move forward with. Rehab, when they go in as a secondary to the start of care, call in. Best practice, call in, have a conversation about, follow a safety-based frequency, assure the 5 elements of care are present. And these are the ways that we start to create defendable, audit-proof documentation and improved outcomes for patient care delivery. Start of care evaluation accuracy, we're looking for things like objective test, looking for some really hardcore measurable data that CMS expects. Again, referring back to Chapter 7, to the 5 elements of documentation and how that made the change there. Short and long-term goals have always been in play. That's something we talk about as well. But how do we get those goals in place as Medicare's looking for that in audits? And how do we do that in a means to improve patient outcomes? Compliance, like I spoke about earlier, and caregiver involvement. Today's day and age, it is important that patients have caregivers with them. Everyone agree with that? And when we can get them present at the start of care, those are lengthy visits with a lot of information. Let's get the caregivers involved. Let's help those patients stay safe in between. And how do we script that, as Arnie has referenced earlier? How do we script successfully at the start of care with the patient involved, the caregiver involved, the physician involvement to really make change for the patient? And a home program. You know, one of the things I say all the time is, for some reason, I used to think this about myself. Patients got better because I showed up at the home, put my hands on them, and did the work. That has never been the case. It is all about the work we do in between the visits. So really getting value out of those visits and applying homework or home exercise programs to each and every visit for the patient to make improvement before we return. In episode management, I'd referenced that earlier and what a crucial piece of the program. Spectrum has employed that and is moving that forward with all nursing and therapy as well. But meeting with each clinician every single week. It's a few minutes. We're using the search tool for the case mix questions that direct the plan of care and the outcomes for the patient to run through, and how different that looks for us instead of coming in and putting out fires all day in a retroactive approach. But how do we start to then do case conferencing every single week on every single patient very concisely off of the plan of care, not all the subjective, and move those pieces forward and identify problems in real time and fix those so we're not in crisis management mode, which is the legacy of home health. We're forever trying to put out the fires. So obviously, like I said, all clinicians meet with their supervisors. This assures the qualified content, documentation's looked at that point, and really continuing to justify documentation and not be in a situation of looking at it after the fact when there's a problem. Safety-based orders, safety being achieved, all big elements of the Oasis and big proponents of the IEMs to assure that patient safety level, again in a patient-centered model, and improve those outcomes. The weekly data runs, we look at a lot of metrics, as Kevin had referenced earlier, about SN visit utilization, therapy utilization, financials, Oasis accuracy. These are all the things through our process that we employed over at Spectrum to track things in real time, to understand where we're at in a very proactive model to make those changes. Kevin had also referenced the weekly leadership calls, and I think that that's a really big piece. Again, at the agency level, it's never about search coming in and fixing all the problems. It's about what we do as leadership to make that change, and how we direct the staff and how we're involved in real time and using metrics to really gauge where we're at and where we're going. I'd like to spend just a few moments. I know I'm running out of time here. But I think it's important to show you the outcomes that Spectrum has achieved. And Kevin had referenced this earlier, and I'd like to walk you through the great work and the great outcomes that Spectrum has achieved throughout this. So if you take a look at improvement in ambulation, and everybody knows how hard it is to get those outcomes up, right? So if you make change now, it's going to show up on your outcomes in about a year. It takes a while on Home Health Compare. Taking a look at Spectrum through the process, through the diligence of applying that process, accuracy at start of care, in-episode management, documentation control, they achieved an improvement in ambulation of 14%. Spectrum's currently at a 4.5 star. They started out at 3.5 star, moved up to 4.5, and on their way to 5 through the work that they're doing. And through this process, what will happen is, as it's hardwired, as we continue to work with them and their other agency as well, is the hardwiring of the processes is what's going to continue them to move from 4.5 to 5 as they're looking at information in real time and sustaining that cultural shift. Improvement in pain, up to 28%. Again, all based on Oasis accuracy. One of the biggest misunderstood questions, patient states she has no pain. The question's not about that. It's about pain that affects movement and activity, and how important through their UR department it was to gain that accuracy at start of care, move it through the IEMs for documentation and efficiency, and then capture that on outcomes. Improvement in respiratory, 25% improvement. And these are big numbers. Improvement in medication management, 19%. Improvement in ED visits, improved 61%. Improvement in hospital readmissions, improved over 21%. So 3.5 to 4.5 stars with a decreased staffing cost of 30%. So again, I referenced earlier, where Medicare's expecting us to go is from volume to value. And so even as we're getting more efficient and reducing the cost of utilization of visits, the improvement in the outcomes are there, and that's value-based. So really great big changes in that. And also I'd like to reference too, a 57% reduction in potentially avoidable events from falls, 57%. By timely initiation of care, by the kickoff from intake, correct information handed off to the clinician timely, from the start of care call for accuracy, for putting services out there that the patient needs to be safe, very timely, and then moving that through, a 57% reduction in potentially avoidable events related to falls. And that's very big in a patient-centered model where you get that value for it and the care that Spectrum is providing. So really well done in those components. So I'm going to turn it back over to Arnie And we're going to talk just a little bit further about some of those other changes. So thank you.
So you can see it all comes down to managing your care at a higher level. Kind of, again, breaking the glass and reinventing it from the value ground up. So I'm going to open it up to questions for a second, but I want to ask some questions to Kathy Sorensen of HCS, who presented with us last year. Kathy, I'm going to ask you a couple quick questions. You heard us 2 years ago and then hired us, and we came and we presented together at last year's VNA annual conference. Did you hear us first 2 years ago? When did you first hear us?
I heard you about 6 months earlier, and when I heard you, I said, oh, I can do this. You just outlined it. I can do this. Went back and realized really quickly we couldn't do this. And so then I saw Arnie again 6 months later, sat in the front row and nabbed him at the end of the session and said, you're hired. Because I realized that we couldn't do it. And I think that's the mistake a lot of people do, is they can't do it themselves.
So we finished a year ago. How are you doing now?
So we have sustained our improvements. It was hardwired, and the benefits are far-reaching beyond what Kim had just outlined to everybody. The new conditions of participation are coming up, and I feel like as I read them, I actually texted Kim and said, did Arnie have anything to do with writing these? Because I feel like we're ready. The case conferencing that we do in episode management, we're already hardwired to do that. We are ready because we already involve the caregivers. The caregiver involvement, that will be not a leap for us to involve. The clinical supervision with the in-episode management, and it just is something I don't think is going to be a huge feat for us. We've managed to maintain, we started out with a 0.9 case mix weight at the beginning of all of this. We were 3 stars. We have managed to maintain a 1.37 case mix weight with average. This is the average. And our average length of stay is 33 days. We elevate our numbers. We went from the 3 stars, and every month we progressed, and we used SHP to measure that. But we are reported at 4 stars, but that's our risk adjustment. But every month we're 5 stars by SHP. So we're very proud of this, and Mary Davis is our clinical director who's implemented that. So.
Thank you, Kathy. Does anybody have questions for Kevin or Kim? Okay, thank you for attending. Be safe traveling home. Hope you had a great conference.